Hello, everyone. Welcome to Colorectal Surgery Virtual Education Series. We're very happy to have Dr. Rodrigo Perez tonight with us. Dr. Perez is going to talk about watch and wait. Dr. Perez has graduated from the University of São Paulo School of Medicine, where he has completed his surgical training under the supervision of Dr. Professor Angelita Habr-Gama. In 2002, he was a visiting research fellow at USC under the supervision of Dr. Robert Beart. He obtained his PhD in 2006 in studying potential molecular targets of gene therapy in rectal cancer. After joining Angelita and Joaquim Gama Institute in 2004, Dr. Perez has concentrated his clinical research activity on the management of rectal cancer. From 2010 to 2014, Dr. Perez was a postdoctoral fellow at the University of São Paulo in the use of molecular imaging for rectal cancer. In 2014 to 2018, Dr. Perez was awarded with Young Research Fund to study molecular mechanisms associated with resistance and sensitivity of rectal cancers to chemoradiation. In 2020, he became the director of Colorectal Surgery Division at Oswaldo Cruz German Hospital, and he runs multiple surgical educational activities funded by medical industry. Currently, he serves at the editorial board of multiple scientific surgical and oncology journals and has contributed with numerous more than 170 publications to the field. Dr. Perez, welcome. Take it away.
Thank you. Can you hear me well?
Yes.
Okay, I'm gonna share my slides. And then I'll start. Please let me know if you see my slides. You should be seeing my slides.
Yeah, we can see your slides. Great, thank you.
Okay, so thank you very much for having me. It's a pleasure to be here again. We're gonna talk a little bit about organ preservation in rectal cancer. This has become very attractive these days for the management of rectal cancer patients, actually worldwide. These are my disclosures. I work for these companies, but perhaps the most important disclosure I have to make is I still work with the lady who actually envisioned this organ preservation idea several years ago, decades actually. The idea was that we were going to avoid TME surgery in a number of patients who eventually achieved a complete clinical response after chemoradiation. Now, the reason we're trying to avoid TME, which is quite an interesting and beautiful operation we all as colorectal surgeons love to perform, I'm sure. The problem this operation is, it is associated with significant morbidity. There's still mortality associated with TME. And there's also several kinds of dysfunction, urinary dysfunction, sexual dysfunction, not to mention fecal incontinence, and even the requirement for temporary or definitive stoma, which are quite significant complications and associated morbidities for a procedure. Now, I have to say that the vast majority of patients who underwent organ preservation in the beginning were actually the result of an accident. And why do I say accident? I say accident because the majority of these patients actually had advanced stage disease. As you see here, these patients actually had advanced stage disease, meaning that they required chemoradiation therapy anyways. They required chemoradiation therapy for oncological reasons, and by accident or by luck or by simple chance, they happen to achieve a complete clinical response. And then we all ask ourselves, so now what do we do with these patients? So that was a story for the majority of patients who underwent organ preservation in the beginning of this story. Now, if you're interested in organ preservation, there's some things that we as a group here in Brazil always believed in. Now, the first concept is organ preservation is for the very distal rectal cancers. So if you look at the MRI, this is a coronal view of an MR, and you can see the red dotted line. So we usually take this red dotted line, which is 1 centimeter above the anal rectal ring. the tumor has to reach beyond this red dotted line to be a very good candidate for organ preservation. Why? Well, basically for two reasons. The first reason is those patients whose tumors are located at this level, they require an intersphincteric resection or coloanal anastomosis or even an APR as an alternative for the management of their rectal cancers. In this particular situation, we believe that if you have a complete clinical response, the risks of doing non-operative management outweighs the risks, or the benefits outweighs the risks of doing such an approach. If you have a tumor as above this line, you're probably better off with a TME without the need for organ preservation. So we really believe that the organ preservation is a good alternative for patients whose lower border of the tumor is beyond or lower than 1 centimeter from the anal rectal ring. And the MR provides an excellent tool for looking at these patients across all institutions and across all situations. The second reason is because these tumors you have the ability of actually feeling the tumors and the response to chemoradiation by the use of your finger. Digital rectal examination remains a very important and very relevant assessment tool for the assessment of tumor response after chemoradiation. So we would only consider patients whose tumors are located beyond this red dotted line because, number one, the benefits outweighs the risks, and two, because you have a tool for the assessment of tumor response, which is your finger. Now, if the tumor is beyond the reach of a finger, it's probably not a good candidate for those same two reasons, because the risks probably outweighs the benefit, and because you are left over with only 2 out of 3 tools that we have to assess tumor response. So what are the 3 tools that we have? Now, number 1 is digital rectal examination, which means that the tumor needs to be accessible to your finger. Number 2 is endoscopy. And you can clearly see how endoscopy clearly spots out a whitish scar, which is consistent with a complete clinical response. You can see some telangiectasia here, but there's clearly no ulceration, there's no mass, there's no stenosis of the rectum. You can clearly see the whitish scar, which is consistent with a complete clinical response from the endoscopy point of view. So that's tool number 2. And tool number 3 is MR. Now, MR in the beginning was used to assess the mesorectal compartment. Why? Because the mesorectal compartment is impossible to feel or to see with your eyes or with your finger. You needed something else for the assessment of the mesorectal compartment. Now, remember, when Angelita started organ preservation strategies for rectal cancer, it wasn't the case that MR wasn't good. It wasn't easy. It wasn't even available. We didn't have MR available at that time. So it was only when MR became to be slowly implemented into clinical practice that we started using MR. And in the beginning, MR was used to assess the mesorectal compartment. Now, the radiologist became so proficient at reading these MRs that they actually can spot out when you have a complete clinical response within the rectal wall itself. So when you see a very low signal intensity area such as this one, the radiologist can pretty much tell you you're probably looking at a complete clinical response in terms of radiology, simply by looking at this low signal intensity area within the EMR. Now, a very important message here. A lot of people ask me, so what if I have a negative biopsy? Now, you got to be very careful with the interpretation of biopsies. A negative biopsy is not the same as a complete clinical response. Why? Because when you have incomplete clinical response, you can see here, this is an incomplete, there's an ulceration here. When you have incomplete clinical response, a negative biopsy will actually reflect absence of residual cancer in less or close to 20% of the cases. This means that in 80% of the cases, the negative biopsy is a false negative biopsy. This is why you have to be very careful and remember a negative endoscopic biopsy is not the same as a complete clinical response. Even though you do have a negative biopsy, it doesn't mean that you can do watch and wait, because there's a very, very high risk that there is residual cancer despite the fact you have a negative biopsy. Now, this doesn't mean I don't do biopsies. It means that I'm very careful interpreting the negative biopsies or the results when they come out as negative. When they come out as positive, they're pretty useful. The problem is when they're negative, you got to be really careful. That's why we stick to the 3 criteria, which are endoscopy, digital rectal examination, and radiology, and not exclusively looking at the endoscopic biopsy as a result or for the assessment of tumor response. Another important concept when you think about organ preservation is organ preservation and achievement of a complete clinical response takes time. Now, if you see this particular patient, this patient is an exceptional case where the patient achieved a complete clinical response after 6 weeks from chemoradiation. But if you look at our data, and this is data from our study looking at patients who underwent TNT regimens, you can see that the majority of patients only achieved a complete clinical response longer than 16 weeks from chemoradiation completion. So it takes time for these patients to achieve a complete clinical response. This is what happens to the majority of patients. You can see here a baseline nasty tumor, and then at 12 weeks, you still see something there's not a complete clinical response yet. And then after 20 weeks, the patient does achieve a complete clinical response. So you got to be careful, because if you're thinking about organ preservation, you have to consider that it takes time for these patients to achieve a complete clinical response. What influences the time to achieve a complete clinical response? Well, looking at our own data, the only factor that was associated with a longer time to achieve a complete clinical response was tumor stage in terms of T stage. T3, advanced T3s or T4s took longer than patients with early T2s or early T3s, T3As. So this was the only factor associated with the time to achieve a complete clinical response. But if you look at the actual averages, you can see that even the early cancers took 19 weeks on average to achieve a complete clinical response, which is quite a long period of time. So if you're thinking about organ preservation, you have to consider that you have to, or you may have to give time to these patients for them to achieve a complete clinical response once they undergo chemoradiation completion. Well, now we are in the era of TNT and nobody talks about chemoradiation anymore, or at least the vast majority of institutions have completely implemented TNT regimens into their clinical practice. And you have to understand that TNT wasn't meant to increase organ preservation. TNT was meant or designed to improve survival. As a collateral damage or benefit, TNT did improve response. It means that if you give additional chemotherapy either before or after radiation therapy, and then also you give some more time, patients who undergo TNT regimens seem to achieve higher rates of a complete clinical response. As of now, the data suggests that the best regimen to achieve a complete response after chemoradiation or TNT is the association of long course radiation and consolidation chemotherapy. Therefore, chemotherapy being delivered after radiation therapy. Why do I say that? Well, because the only 2 studies that looked into response as a primary endpoint was the German study and the OPRA trial, and both of them used long course chemoradiation therapy and then either induction or consolidation. And the regimens that incorporated consolidation chemotherapy in both studies did show an improvement in the rates of complete response. It's true that the German study looked into complete pathological response rates, while the OPERA trial looked into complete clinical response rates. But the matter of fact is that both studies did show that consolidation was better than induction chemotherapy for the specific achievement of a complete pathological response in the German trial and clinical response in the OPERA trial. We ourselves have been using chemoradiation therapy with consolidation chemotherapy for a long time. You can see here we published our data in 2009, long before TNT was even called TNT. We were already using consolidation chemotherapy, not only during radiation therapy, but also during the resting period, with the difference that we were delivering to patients only 5-FU consolidation chemotherapy. The idea was not to improve survival at this point. We were only thinking about improving response. And the truth of it is, we did find an improvement in the response rate when we published our first preliminary data, showing more than 50% of patients achieving a complete clinical response with long course chemoradiation therapy followed by consolidation chemotherapy. But there's an important concept here, because once you achieve a complete clinical response such as this one here, and you can clearly see the whitish scar again, then it doesn't matter what kind of chemoradiation or TNT regimen you have done. It doesn't really matter, because you have the single most relevant biological feature. The fact that you have achieved a complete clinical response outweighs, is more relevant than any other feature. It's more relevant than initial baseline staging. It's more relevant than the actual chemoradiation therapy regimen. It's the most and the single most important feature in a successful organ preservation strategy. This is an interesting graph, and you can see the survival curves here. And the survival curves in terms of the local regrowth-free survival, that means recurrence-free survival, improves as you achieve and sustain a complete clinical response for a number of years. So if you look at the blue curve is patients at time 0 when they achieve a complete clinical response. But if you look at the orange curve, these are patients who achieved a complete clinical response and sustained a complete clinical response for 1 year. And you can clearly see that the local recurrence-free survival is better. And then if you look at the green curve, these patients were the ones who achieved a complete clinical response and sustained it for 3 years. Local recurrence-free survival improves even more. So the most relevant and the most important feature in a successful organ preservation strategy is achievement of a complete clinical response and the sustainment of a complete clinical response over time. These are the most relevant features, much more relevant than the actual chemoradiation regimen or the TNT regimen whatsoever. Now, I started my talk saying that the majority of these patients achieved a complete clinical response in organ preservation strategies by accident, because most of these patients had advanced stage disease and required chemoradiation therapy anyways for oncological purposes. Well, this is now changing. We are more and more seeing patients who have early stage disease, T2 and 0 at the level of the anorectal ring, who would otherwise be a candidate for intersphincteric resections or even APRs for functional outcomes, are being managed by chemoradiation therapy or even TNT regimens, where the sole purpose of treating them with TNT or chemoradiation is for the purpose of achieving a complete clinical response. So patients like this one, you can see this is a T2 and not disease at the level of the anorectal ring, and you can see a complete clinical response has been achieved after TNT regimen, where the sole purpose of treating these patients, or this particular patient with chemoradiation, was not oncological reason, but for the achievement of a complete clinical response and avoiding TME altogether. Now, there's a question whether early rectal cancer really needs TNT. If you think about it, it's quite a paradox. We're actually treating patients who didn't even need chemoradiation for oncological reasons. We're not only treating them now with chemoradiation therapy, but now we're even thinking about a more intensified treatment regimen with not only chemoradiation therapy, but also with total neoadjuvant therapy with consolidation chemotherapy for T2s and zero disease. It's quite a paradox. But when we looked at our own data of early rectal cancers treated by TNT or regular chemoradiation therapy, where the sole purpose of treating these patients with chemoradiation therapy was to achieve a complete clinical response. And you can see that those patients with early stage disease who were treated with TNT had nearly double the chances of achieving a complete clinical response. So it does make a difference. If you're treating your patient for the purpose of achieving a complete clinical response, you're probably better off treating those patients, even when they're early stage disease, with a TNT regimen rather than the old style chemoradiation therapy. That's why we're running a prospective randomized clinical trial now in Latin America, randomizing 2 different types of consolidation chemotherapy for patients with early rectal cancer. We're using long course chemoradiation in both arms, and one of the arms receives 5-FU only consolidation chemotherapy as opposed to FOLFOX or CAPOX, so 2-drug chemotherapy consolidation, to see whether there's a benefit of treating these patients with oxaliplatin, considering the fact that oxaliplatin is associated with significant toxicity, and we're not really looking at survival, since these patients with early rectal cancer, the only benefit of treating them with chemoradiation therapy or TNT is the achievement of a complete clinical response. So we're running a trial with 1 drug or 2-drug consolidation, using as a primary endpoint complete clinical response, to see whether there is any benefit of adding oxaliplatin to the consolidation part of the treatment. Now, the problem with organ preservation is clearly the risk of local regrowth. This is the nightmare of organ preservation. Everyone who does organ preservation, watch and wait, after a complete clinical response is terrified with the risk of a local regrowth. Now, a local regrowth, you have to think about it, is not a recurrence of the cancer. It's the same cancer, just growing back again. So it's not a local recurrence in the sense that we did TME and now there's a local recurrence coming from outside of the TME. This is within the rectal wall itself. It's the same cancer, just growing back again. Now, important messages about local regrowth is, number 1, the vast majority of local regrowths occur within the first 3 years of follow-up. You can see the curve here, and it plateaus after 3 years. It means that 98% of local regrowths develop within 3 years of follow-up of these patients. And it happens in 1 out of every 4 or 5 patients. So it's quite significant. It's quite frequent to see a local regrowth. When you see 1 out of every 5 or 4 patients, it's quite a significant amount of patients. Now, this is why we are so intensive in the surveillance within the first 3 years of follow-up. To be honest with you, we're actually obsessive with local regrowths. And that's why we see these patients for the first 3 years almost obsessively, every 2 months or every 3 months at the most, for the first 3 years, using all 3 assessment tools. Remember, digital rectal examination. If you don't have that, you are already lost with one of the important assessment tools. Rectoscopy is really important. I'll show you some interesting data about it. And also MR has become an integral part of the surveillance strategy for these patients. We obviously follow them for longer periods of time. We're not really sure for how long we need to follow them. We still follow them for life, as as we speak because we really don't know. We did see a couple of local regrowths 7 or even 9 years away from the primary treatment strategy, but with the majority of these patients follow a surveillance, a very intensive surveillance program is really concentrated in the first 3 years of follow-up because of the increased risk for local regrowths within the first 3 years. What are risk factors for local regrowths? Well, the only risk factor that we know of is baseline T stage. The more advanced the T stage, the higher is the chance for a local regrowth. Easy to remember. T2, 20%, T3, 30%, T4, 40%. And apparently, nodal disease is not associated with the risk of local regrowth. None of the series, and not even our own series, had any association between nodal status and the risk of local regrowth. T stage is associated throughout most of the series, but nodal disease has not been associated with the risk of a local regrowth. Now we have more important messages about local regrowth, and this is really important. 95% of local regrowths have an endoluminal component. So you will have a T stage for 95% of the local regrowths. Now, if you think about it, if 95% of the local regrowths have an endoluminal component, it means that endoscopy and your finger should be able to detect 95% of these local regrowths. So it's really important for their surveillance that you have these two abilities, that you have these two tools at hand. So if the patient has a very upper distal or upper rectal cancer or mid rectal cancer that you can't reach, it may become a problem, as you will see in one of my following slides. So yes, the finger is really important because sometimes these local regrowths may be missed by some of the gastroenterologists and some of the unaware endoscopists that are surveilling these patients. This is a very good example of a patient of mine, and you can see how it looks like almost a perfect scar. However, there's something wrong, and it's wrong with the digital rectal examination. There was nothing wrong with endoscopy. We didn't see any ulceration, but when I felt with my finger, I said, there's something wrong here. There's something nodular about this, and there was cancer there. So you have to be careful because sometimes the only tool that will be able to detect the local regrowth is going to be your finger. So be careful with that. What about endoscopy? Now, this is another example of mine, and you can see it looks like almost a perfect scar. It looks like a complete clinical response, doesn't it? Well, when you apply NBI, you can see some funny areas in the periphery of the scar. You can see the scar is here, but if you see in this green area, there's a funny little area that is a different color. This is another example. You can see the perfect scar on your left, but at the same patient with the same case, when you apply NBI, you start seeing some very funny areas that you can easily see with the NBI, and sometimes not quite easy with the regular endoscopy. So yes, NBI has to be used in every and each case that is being assessed and surveilled for a complete clinical response. So very important, digital rectal examination, endoscopy with NBI. And number 3, obviously, radiology, MR. Now, MR, in my experience, is the least important of the diagnostic tools of a local regrowth. It is rare the case. It is rare the situation when MR only, exclusively, will detect a local regrowth. But I do have examples for you. This is an example of a case of mine who was actually only detected for a local regrowth because the rectal wall showed significant thickening within the MR images. We could see nothing. We could really palpate nothing really, but in radiology, we saw a progressive thickening of the rectal wall. There was cancer there. Another example for MR, which is quite rare, but also possible, is the situation where you have a complete clinical response at the level of the rectal wall. As you can see here, the white perfect scar. But then when you look at the MR, there's a nodal enlargement that is progressively larger in subsequent MRs. And you can see here, you can see the nodal local regrowth, which is quite unusual, but may happen. We have less than 5% of the cases where you have no regrowth within the rectal wall and exclusive disease within the mesorectum. So you have to be careful. And this is why MR has become really important, because it's not zero. There is a risk for an exclusively mesorectal local regrowth. Now, in the beginning of our experience, everybody was concerned that a local regrowth was going to become unresectable disease at the time of diagnosis. I still remember the time where we came to meetings and then people asked, well, if you have a local regrowth, then you messed it up. There's no way you're going to salvage this patient. Well, if you look at the available series, 95% of the majority of the series show that patients who have a local regrowth, yes, are amenable to salvage resection. And to be honest with you, we end up doing the same operation we intended to do in the beginning. So if the patient was a candidate for an APR and has a local regrowth, at the time of local regrowth, he or she are probably going to be a candidate for an APR anyways. If the patient was a candidate for sphincter preservation operation, at the time of local regrowth, usually you will be able to do the same operation you intended to do in the beginning. It is rare the situation where you had a case which was a candidate for a coloano and then becomes a patient who needs an API. That's not very frequent. Number two, we did have some patients that we were able to actually do a local excision for the salvage of a local regrowth. You can see here a patient that we're doing a local excision for the salvage of a local regrowth. And when we looked at our own data to see what were the outcomes of these patients, and we were surprised that patients with the local excision actually did better than patients who were managed by salvage TME. Now, be careful with the interpretation of the data here. The reason that the local excisions did better than TME is simply or probably due to the fact that the majority of patients who were salvaged by local excision were actually stage 1 at baseline, meaning that the majority of these patients were actually T2s at baseline, and that was the reason that local excision was feasible and very successful in the management or for the management of a local regrowth. So yes, we can do local excision for the salvage of these patients, but I would only recommend to do so among patients who have a baseline T2 rectal cancer for their initial baseline staging. And that's probably the reason why local excision did so good in our series, even better than TME for the salvage, meaning that TME we're probably dealing with patients with more advanced disease at baseline and probably at the time of a local regrowth. So yes, we can salvage these patients. We usually end up doing the same operation we've intended to do in the beginning, and in very specific cases, yes, we can do local excision for the salvage of a subset of these patients. Now, the real nightmare seems to be distant metastasis, and we're not really sure whether this is a significant problem or not. It has to be, you have to be careful, even though you have a complete clinical response, there's still a risk for distant metastasis. Even if you have a complete pathological response, there is a risk of distant metastasis among these patients. Now, the first study that actually pointed out that patients who had local regrowth had increased risk for distant metastasis was the series from the Memorial Sloan Kettering. You can see here, this is available in their study, and you can see how low patients with a complete clinical response and subsequent local regrowth did have an increased risk for distant metastasis compared to patients who had a complete clinical response and no local regrowth. Now, this data was from very small number of patients, so we weren't really sure what was going on here. So we looked at this into a larger data set, and we looked into the International Watch and Wait database. And when we looked at the International Watch and Wait database, we were looking at nearly 200 local regrowths out of almost 800 patients with a complete clinical response. So a very significant cohort of patients. And if you look at this multivariate analysis, the only risk factor for distant metastases among patients who ever achieved a complete clinical response was the fact that patients developed a local regrowth. Local regrowth was the single unique risk factor for subsequent distant metastasis. T stage was not, N stage was not, the type of chemoradiation, the amount of radiation delivered, none of these features had anything to do with the risk of distant metastases. The patients who developed local regrowth seemed to be at a higher risk for distant metastases. Now, if you think about it, we usually tell our patients when they complete 5 years of follow-up, we congratulate them. 5 years out of initial baseline staging and you have no recurrence, congratulations, open and champagne, you're probably cured of your disease. Why? Because the risk of distant metastasis after 5 years of the diagnosis is very rare. Even if patients, when you have a complete clinical response managed by watch and wait, if you have no local regrowth and you complete 5 years, the risk is minimal. However, when you have a local regrowth, the risk only becomes minimal once you complete 5 years, not from the baseline cancer, when you complete 5 years from the local regrowth. It's like your clock needs to be reset to the time where you achieved or developed a local regrowth. It's like your clock starts clicking again. It's like you have a first hit for the risk of distant metastasis, and then you have a complete clinical response, and then you have a local regrowth. Well, then you have to start counting over, and you only start counting over 5 years from the time of local regrowth and not from your baseline cancer. So you have to be careful about local regrowth. Now, think about it. A local regrowth is an incomplete response. It's never been a complete response. You've mistaken for a complete response. You thought it was a complete response. It wasn't really. It was never really a complete response. You thought it was. So when we compare the risk of distant metastasis between local regrowths and complete responders, we're really comparing apples to oranges. Why? Because a local regrowth was an incomplete response, and a watch and wait, a successful watch and wait, is a complete response. So we're comparing complete to incomplete responses, which is actually not very fair. And it's probably not surprising that the risk of distant metastasis are different between those two subgroups of patients. So we thought we should compare patients with incomplete responses or local regrowths. Instead of comparing them to complete responders, we thought that we should compare them to incomplete responders. So we should compare incomplete to incomplete. And when we do that, there seems to be no differences in terms of the risk of distant metastasis. Patients managed by TME at the time of regrowth, or patients managed by TME after chemoradiation completion, had similar distant metastasis rates. We saw that in a retrospective series a long time ago, and you can see here, patients that we thought were complete responders, but were not, and they had a local regrowth, disease-free survival was no different from patients managed by TME up front, but with incomplete response. As a matter of fact, the OPRA trial showed the exact same survival curve. You can see here, the blue line refers to patients with TME after an incomplete response immediately after chemoradiation completion. And the red line refers to patients with local regrowth managed by TME only at the time of local regrowth. And you can see how disease-free survival was not different between those subgroups of patients. So when you think about it, when you compare local regrowths to incomplete responses, there weren't really any differences in terms of disease-free survival. But I think that comparison is also not fair. I think it's also unfair. Why do I say that? Because a local regrowth had something in between that was an almost perfect response. And patients managed by TME had never almost perfect response. They actually had minimal response. So we're comparing patients with different initial responses to chemoradiation completion as they were the same. So when we try to balance for this intermediate response, we used the local regrowths as a group with intermediate excellent response, and as a control group, patients who had near complete pathological response. These patients had very good response, but still incomplete. Now, it's not a perfect control group, but it's probably the closest to what a local regrowth is. Patients who have excellent response, but still had minimal microscopic residual disease. And when we do the comparison of distant metastasis between these patients, you can see how local regrowths do worse in terms of distant metastasis. Salvaging patients with TME at the time of local regrowth, when the local regrowth is a YPT3 or 4, is worse than doing a TME up front after a near complete pathological response. So apparently, there's still something we need to understand about the risk of distant metastasis among patients who have a local regrowth, and we're not really sure that the risk is the same as doing TME up front for these patients in terms of risk of distant metastasis. So in summary, we now know and understand exactly what the criteria of what a complete clinical response is. And I strongly suggest that if you're thinking about organ preservation, these three criteria need to be fully implemented before you actually think about doing organ preservation. And to be honest with you, I strongly believe that endoscopy and digital rectal examination are the two most relevant ones. Be careful with endoscopic biopsies. You should not be using a negative endoscopic biopsy to use it as the meaning of a complete clinical response. So it doesn't give you the right to do organ preservation because you have a negative endoscopic biopsy, particularly if you're not looking at a complete clinical response. You got to think about organ preservation now ahead of time. You shouldn't be thinking about watch and wait once you, by accident, achieve a complete clinical response. You have to think about organ preservation at the time of treatment of these patients. Is organ preservation an expected outcome? Are we thinking about this, or is this something we're not interested in achieving here? Local regrowths, yes, they're usually amenable to salvage surgery. Usually we do the same operation we've intended to do in the beginning. And yes, for patients with early stage, local excision may be an option for a select group of patients with local regrowth. But be careful, we still do not know whether local regrowths may be at a higher risk for subsequent distant metastasis development. Once you have an unsuccessful organ preservation, you have a local regrowth, you got to be thinking that this patient is at higher risk than patients with complete clinical response to develop a distant metastasis. So be very careful. I usually show this slide because people don't really know how to do this in terms of timing. And this is how we do it. And this is exactly how we are doing this in our randomized clinical trial. We often see these patients after 6 weeks from the last day of radiation. Why? Because we always think about consolidation when we're thinking about organ preservation. So we do long course radiation and we start assessing tumor response at 6 weeks from chemoradiation. We count the last day of radiation to calculate 6 weeks. And that's when we perform our first assessment. This first assessment is not used for management purposes. We're going to use the 6-week assessment response to compare it with the 12 weeks. The 12 weeks needs to be showing that it is improving from 6 weeks, and you got to be looking at a very promising near complete or almost complete response at 12 weeks. Those patients may be deferred for an additional assessment at 18 weeks, or if the patient has already achieved a complete clinical response at 12 weeks, these patients are enrolled in a watch and wait program. We rarely extend the assessment of response beyond 18 weeks. Obviously, we may have exceptional cases, but the majority of patients should be able to have achieved a complete clinical response between 12 and 18 weeks from the last dose of radiation, provided you have treated your patient with long course radiation and consolidation chemotherapy. This is a group of people I work with, and I thank you for your attention. I'll be happy to take any questions.
Thank you very much. That was a great lecture, Dr. Perez. I have some questions in the chat. I will ask them. Dr. Modi is asking, how do I convince my med-onc and rad-onc colleagues to give TNT in early stage tumors? I do get some resistance when I mention it in tumor board. What would you suggest?
That's a great question, Modi. This has been a matter of discussion everywhere. Even here, sometimes these patients are discussed in our MDT, and nobody wants to give them TNT. I think that the med-oncs have to understand that this is a discussion that you need to have with your patient and understand what the expectations are. That's number one. Number two, sometimes even though you are able to perform an anastomosis, med-oncs have to understand that if some of these anastomoses may fail, and once they fail, sometimes they fail for good. And patients who were otherwise candidate for a primary anastomosis end up with a definitive stoma. And finally, these operations, they're associated with significant morbidity and even mortality. And if you have a complete clinical response in very distal rectal cancers, I think that these patients actually benefit. Now, my suggestion to you is start off with the really distal ones. I would never suggest such a treatment for patients with mid-early rectal cancer. These need to be patients with T2 and zero disease at the level of the anorectal ring, where otherwise they need an intersphincteric resection or even an APR for functional reasons. This needs to be an alternative to the very distal, more morbid, and even where the margins become more critical, because a T2 in the very distal rectum it becomes a risk factor for a positive margin. So I think these are the arguments that we've been using for a long time, and we've been successful. Once they start seeing the complete clinical response or the successful cases, they will see and understand why this is a rather reasonable approach for these patients.
Great. Another question from Virgilio. What are your specific indications for local excision and local regrowth after TNT?
Okay, so local regrowth, to be treated by local excision, has to be several features need to be present. Number one, it has to be preferably early stage in the beginning. Number two, at the time of local regrowth, this is a very small, questionable ulcer, or even small and superficial. You have to see nothing within the mesorectum, nor at baseline or at the time of local regrowth. And finally, it needs to be very distal. So it has to be either for a coloanal intersphincteric anastomosis or an APR as an alternative. So if you follow these rules, very distal, baseline early stage disease, nothing in the mesorectum, and seems small and superficial, these are the patients we would consider for a local excision at the time of a local regrowth.
Dr. Madi is just answering that their concern is that the 50% that will not respond are getting overtreated with the chemo, and that's the argument.
That's true, Modi, but if you think about it, and if you look at the ACOSOG trial or even the Grecar study, a lot of these patients will not achieve a complete response, but will still be able to be good candidates for a local excision. If you think about the ACOSOG trial, they had a very low local recurrence rate, and at the end of the day, nearly 85% of the patients were actually treated by an organ preservation strategy, either watch and wait or a local excision. So I think the 50% is not being fair. You're actually looking at perhaps maybe only 15% of patients will not be able to undergo any kind of organ preservation strategy. And yes, you may be over-treating these patients. At the end of the day, Modi, you got to think about it. The med-oncs are the biggest people over-treating patients. They're over-treating even patients with locally advanced rectal cancer sometimes are being over-treated because you have a questionable T3 and a suspected node. This is, it's true. You may be over-treating a proportion of these patients. But when you think about it, and you can still provide them organ preservation, either through watch and wait or local excision, for the very distal ones, I think is a good bargain.
Great input, thank you. Dr. Kaminsky is asking, thank you for a wonderful talk. With your data on possible increased metastatic disease and local regrowth, are you pushing a proximal rectal cancer with a clinical complete response to TME?
So let's clarify. I am completely against watch and wait for upper or mid rectal cancer. I don't believe in watch and wait for mid or upper rectal cancer for many reasons. Number one, because you fail to detect local regrowths, and number two, because we're starting to see some risk of subsequent distal metastasis among these patients. So I think there's a real risk for doing watch and wait for these patients. I only think that the risk is outweighed by the benefit of avoiding TME for the very distal ones. And that's why I use the 1 centimeter above the anal rectal ring as the cutoff margin for indicating organ preservation to these patients.
Great. Dr. Tanchu is asking, what an amazing and comprehensive lecture on this ever-evolving topic. I have a few questions. For a watch and wait strategy, do you get any radiographic studies to evaluate for metastatic disease? And what's your protocol? And as we see more and more rectal cancers in young patients, what are your thoughts on surveilling patients for more than 5 years? I've seen a few young patients with recurrence 8 to 10 years from treatment.
So question number one is, how do we surveil for metastatic disease? We usually surveil patients as we do for any rectal cancer. So we follow the metastatic surveillance as we do for any rectal cancer. Now, you got to be really, really concerned when you have a local regrowth, because now you know you have a local regrowth. That's a risk factor for distant metastasis. So you got to be careful with those patients. But we usually surveil them as we do for any rectal cancer. Now, patients under 50 or patients with young age onset rectal cancer, we believe those patients benefit the same as those who are with old age. So if you think about early or young patients, they benefit because they benefit for a longer period of time of maintaining the rectum and for functional reasons. And for the older patients, you actually avoid a quite morbid operation. So I think both patient populations benefit the most. And looking at a database from the International Wash and Weight database, we actually looked at the 50-year cutoff to see whether there were any differences in terms of outcomes. And patients who were young did the same as patients who were old in terms of outcomes. So we do organ preservation regardless of initial age. It's true that we still need to follow these patients for life. We don't really know when we should stop following and surveilling these patients. We surveil them for life. But I think that as we have improved MRR and improved distant metastasis surveillance with the current CT protocols, we are actually picking up much earlier local regrowth. So I think it's going to be rare, the situation where we see very, very late local regrowth. But I do agree with you, it's not impossible. That's why we're still surveilling these patients for life.
How often do you do CAT scans for distant metastasis?
So we would do, for the first 3 years, we would do every 6 months CAT scans to surveil for distant metastatic disease. Remember, when you have a local regrowth, you got to reset. So the first 3 years begin again after the local regrowth, meaning that you're not doing every year after the 4th year once you have a local regrowth in year number 3. So you have to reset your clock if you have a local regrowth. So we would do every 6 months for the first 3 years and then yearly thereafter.
Dr. Lee is asking, when you're planning for an APR or not considering like complete clinical response, what's your neoadjuvant protocol? What's your group's neoadjuvant protocol?
That's a good question, Lani. We are always thinking about organ preservation. So it's rarely the case that we say, okay, we're not going to do organ preservation. No way. You know, sometimes you'll be surprised. So we always think that the regimen that provides the best chances for complete response, and when you need so significant response, we always use long course chemoradiation and consolidation chemotherapy. Now, the only exception to this is patients with metastatic disease already at baseline. Patients with metastatic disease, then it's a long discussion in the MDT. We got to think about what are the priorities that we are looking at for each patient. So in the vast majority, long course consolidation chemotherapy. I hate short course and consolidation. The repeater trial to me is a failure. So we would only consider short course very selectively in patients who have metastatic disease that really need radiation, but we got to start very shortly with the chemo because otherwise the patient is going to do bad. That would be the only situation we would do it short course. The vast majority of patients, again, we would do long course and consolidation chemotherapy for non-metastatic disease.
Great. Another question from Dr. Modi. Are there any markers, biological or otherwise, which can predict the 50% of the patients who will not get a complete response to TNT in early stage tumors?
That's a great question, Modi. We've been looking at this for a number of years. I think we spent millions of dollars and found zero. No good and reliable marker for tumor response, except for one, which is microsatellite unstable disease and the use of immunotherapy. Other than that, we don't have anything. But the problem is, at least at our center, less than 5% of the rectal cancers are actually microsatellite unstable. So that's the only real marker that we can rely on. And unfortunately, we don't have any other markers that can reliably predict response to chemoradiation. We've been looking for many genomic factors, proteomics, and so on. And to be honest with you, I am a little bit disappointed. We wasted and lost a lot of money and found no good reliable markers so far.
Dr. Syed is asking, great talk. During the follow-up in watch and wait period, are you using ctDNA marker like Signatera?
Yeah. So ctDNA is one of the new kids on the block, and everybody wants to use it. And unfortunately, for organ preservation, is not ready for prime time. Why? For two reasons. So when you have a negative ctDNA, we still may have microscopic residual disease. There are many patients who have negative ctDNA after chemoradiation, but still have their primary within the rectal wall. That's number one. And when your ctDNA is positive, is it coming from the primary or is it coming from metastatic disease? So we don't really know how to interpret patients with positive ctDNAs once you have a complete clinical response. So you may have a significant amount of false negatives and you don't really know how to manage with the positives. So we still don't use ctDNA for management purposes. We think it's a promising tool, but it's not ready for prime time yet for this particular purpose.
Great. Dr. Chancho has another question. How would you manage a patient who developed metastatic disease but no local regrowth while under watch and wait protocol? Would you resect primary after chemotherapy if there is resolution of the metastatic disease?
That's a very good question, and that's a challenging one. So if you have metastatic disease without a obvious local regrowth, I would really be concerned that there is residual microscopic disease that we're not seeing. It is not impossible to have metastatic disease only, however, is not frequent. So that's number one. I would be really concerned about a local regrowth that is subclinical. That's number one. Number two, yes, you can treat the metastatic disease, and I would either chemo or resect it, whatever the MDT thinks if there's a possibility for cure, we would definitely go for it. But I would be really obsessed in ruling out that there is no residual or a local regrowth within the rectal wall for this particular patient. Does that make sense?
Great, yeah. In your series, Dr. Hashem is asking, any consideration for immunotherapy and when?
So immunotherapy is only used for patients with microsatellite unstable disease. The problem is immunotherapy is still very expensive. It has been only used in the setting of trials so far. We are not allowed to use, it's an off-label use for rectal cancer still. So we're still learning how use immunotherapy for microsatellite unstable disease. Yes, only for the microsatellite unstable, which represents less than 5% of the cases, and usually within the setting of a trial.
Dr. Lee is asking, I'm curious, what's your counseling patients about the watch and wait? Do you talk to them when they get diagnosed or after TNT, and how do you counsel them?
It's the other way around. They usually come to me because they know about watch and wait, and they counsel me on what they want. It's not, so it's usually, I have a hard time sometimes telling patients and convincing them that they have T2, T3A, mid-rectal cancer. They're better off with a TME, but they want to do chemoradiation for the purpose of achieving a complete clinical response, which I'm against too. But sometimes I have a hard time convincing them that the risks of doing chemoradiation therapy in this situation is actually not a good alternative. So that's my challenge number one. I usually don't have a hard time counseling them for watch and wait. They usually come to me because they're interested in achieving a complete clinical response, and they already read and learned about everything. They lecture me on watch and wait, really.
That was gonna be my next question. I see patients with mid-rectal cancers too, and they wanna do watch and wait. Do you treat them or do you refer them?
So this has become hysterical now. Everybody wants to do chemoradiation therapy for the achievement of a complete clinical response, and usually it takes me an hour and a half or 2 hours sometimes, but they most of the times understand. Of course, obviously, everyone has an exceptional case. You know, a 125-year-old patient who doesn't want to do surgery, and or you can come up with several exceptional cases, but the majority of healthy patients with mid-rectal cancer who are mesorectal fascia are clear. Usually, we try to convince them that they do not need chemoradiation therapy for the purpose of achieving a complete clinical response. They're probably better off with a TME, unless the tumor is very distal, and the other alternative is one of the APR or intersphincteric resections.
I have one last question. Dr. Hashem is asking, have you seen any obstructive scar after TNT and how to manage?
Have I observed? I'm sorry?
Any obstructing scars?
Oh, yes. Yes. So I have seen a few stenosis following chemoradiation therapy, particularly for patients who have more than 60 or 70% extension or circumference of the rectal wall. Some of these patients, the scarring is so significant that they actually develop a stenosis. We avoid doing watch and wait in those patients, particularly if you have to dilate or do anything because the stenosis has become symptomatic. Those patients are clearly not the best candidates for watch and wait. But some of these patients have a quite significant narrowing of the rectal lumen, but you can still properly surveil them endoscopically and with your finger. And some of these patients were actually managed by watch and wait. So it's a gray area. You got to be careful with the stenosis. And if it doesn't feel soft and it doesn't feel nice, you should definitely not be watching and waiting on those patients.
Okay, great. Thank you so much, Dr. Perez. This was great. Thanks everyone for joining and asking questions. Have a good night. Thank you.
Thank you.